to get a diagnosis of the cyst. So it's a pelvic ultrasound or sonogram, the same thing, right? So we're examining the ovarian cyst, and then with an ultrasound, we can tell if the cyst is large or small. We can tell if it's fluid filled, if it's solid, or both. And then from that, a proper diagnosis and management is determined. Sometimes MRI can be helpful for further evaluation of these cysts. They're called complex, so cysts that have some solid components. Sometimes we'll get an MRI. CT scan, typically not really useful for ovarian cysts, but in some cases, let's say if cancer is suspected, CT scan is helpful to look at other structures to see if there's any abnormal tissue or tumors outside of the ovary. Blood tests are typically not all that helpful for ovarian cysts. I know a lot of doctors will get what's called tumor markers. Typically they're, come back normal. If we're suspecting ovarian cancer, tumor marker might be useful, but keep in mind that something like CA-125 can be abnormally elevated in benign conditions. So it's not specific for ovarian cancer. And then again, in younger patients, 99% of these masses are benign. In even older patients, 90% of the masses are benign. So it's really, the tumor markers are sort of not all that helpful. Now, what are the type of cysts? So you can have a functional cyst, right? So let's say if you had an ultrasound for whatever reason, maybe it was pain or abnormal bleeding, and your OBGYN told you, oh, you have a cyst, but it's nothing to worry about. It's a functional cyst or it's a hemorrhagic cyst. So functional cysts are part of normal ovarian function or cycle, right? They form during the menstrual cycle, then they go away, then another cyst forms, and then it goes away. So if you're not on a birth control pill or on any medication that prevents ovulation, every month a cyst forms as part of the ovulation process. A hemorrhagic cyst is just a functional cyst with some blood inside. They typically do not cause pain. Sometimes, if a hemorrhagic cyst sort of gets very large and then ruptures, that spill of that blood can cause some pain and irritation, but it resolves. So this is kind of short-lived. It's very rare to have a sort of a bleeding, ruptured ovarian cyst requiring surgery. So most of these do not require surgical intervention. And then if you want to prevent functional cysts or hemorrhagic cysts, you would just go on a birth control pill, and that would prevent ovulation. See? All right. So what if I have a pelvic pain, but my ultrasound shows functional cyst, right? So again, functional cysts typically do not cause pain. So if you had an ultrasound and the only thing it showed was a functional cyst, most likely the source of the pain is not the cyst, but maybe endometriosis, right? Because endometriosis, little spots of abnormal tissue growing in the pelvis, cannot be seen on ultrasound. So you may be seeing a cyst, more of a kind of an incidental finding, but what you probably have is endometriosis. But in order to diagnose it and address it, a laparoscopy is required. Birth control pills do not make endometriosis go away, but they can relieve some of your symptoms. So what are complex cysts? So complex cysts is anything that's not a simple cyst, right? So we said a simple cyst is one pocket of fluid. It could be big or small, and it's filled with clear fluid. There are no walls inside the cyst. There are no solid components. So if anything but that is going to be automatically a complex cyst. Complex cyst does not mean something bad. And again, most are benign. There are different types of benign complex cysts. A dermoid cyst is very common. We'll go over that. Ovarian cyst with torsion, endometrioma, cystadenoma, or tubo-ovarian abscess, and we'll go through all of those. So basically, again, just to review, simple cysts, these are nothing to worry about and typically do not need surgical excision unless there's some pain and we're thinking something else may be going on. So dermoid cyst, first type of complex cyst. So these are very common. They're very common in young people. They can be found on both ovaries at the same time. All right. And so this is a picture. You have a uterus here, and you have a very large right ovary with a dermoid cyst. So it's important to note here that the cyst is inside, right? So it's not like a little thing that's sitting up on top of the ovary. It's actually within the ovary. So the ovarian tissue stretches as the cyst continues to grow. And then here you have the normal left ovary and a normal fallopian tube. Here you can't even see the fallopian tube, it's somewhere behind. There's the end of it here. So dermoid cysts very commonly twist on themselves. So twisting of the ovary happens because the cyst, like it's very mobile or floppy. The ovary becomes very round rather than flat like a pancake. And so it's more prone to sort of twist on itself. But because it's large, it sometimes gets stuck in that twisted position. The twisting will cut off its blood supply. So it's very common with dermoids to present as a torsion. So you may not know that you have a dermoid cyst, and then all of a sudden you have pain, you go to the ER, they do an ultrasound, they say, oh, you have twisted ovary, and this is probably due to the dermoid. It requires surgical excision. Okay, so there's really not much you can do with these. They're, solid tumors. They have teeth, hair. These do not go away with time. They do grow over time. They grow pretty slowly. So if you have a small dermoid, doesn't mean you need to, run and get it removed tomorrow, but it's going to be eventually need to be removed. So it's kind of one of those sooner than later thing. Now, important thing to know is that, if you do wait, so let's say you say, well, I don't have any pain. Okay, fine. I have this dermoid. I'll just wait and see kind of what happens. Maybe I do it later in a few years. So as it grows, so not only again that we have to worry about torsion, but it also is going to kind of thin out and stretch out the normal ovarian tissue. And probably eventually as it gets big enough, you're not going to have much of an ovary left. It's just going to be a big dermoid cyst with a paper thin ovary there. So that ovary is not likely going to be functional anymore. So if you're trying to preserve your ovarian function, it's better to remove it. If you're thinking about getting pregnant in the future, you really want to remove the dermoid before getting pregnant, because if you do have torsion during pregnancy, you're going to need to get surgery during pregnancy, which, you don't want to have to do if you don't have to. So, and fun fact, as like I said, they have teeth and hair inside. It's really weird, but sort of cool at the same time. Now, ovarian torsion, I kind of covered that already. So it's the twisting that happens on the ovary. So it twists on itself and it just cuts off its own blood supply. So when we do the surgery, we see this sort of blue-black ovary because it's dying, it's dead, right? Most of the time, unless the surgery is done immediately, most of the time the ovary cannot be saved and the entire tube and ovary is removed because they're necrotic or dead, right? And other than dermoids, this can also happen in patients who've had a hysterectomy. So if they don't have a uterus here, then really the ovary is only suspended on one side. And so it's a little bit more likely to kind of twist around. But first it would have to have a cyst on it, right? So a normal ovary doesn't torse because it's like a little tiny pancake. But if an ovary develops a large cyst, then it's more prone to torsion. And again, dermoids are more common to cause torsion. All right, endometriosis cyst, also known as endometrioma. This is a different type of cyst. It's also considered a complex cyst, also very common in young people, often causes significant pelvic pain. So it's very unusual for someone to have an endometrioma and not have pain. It could be pain during menstrual cycle, could be pain most of the time. It often causes infertility because it destroys the normal ovarian tissue. And what do we have in the ovaries? We have little follicles with eggs in them. So if those eggs are destroyed, then you can't get pregnant. Endometriomas do require surgical excision unless they're very, very small, and they were found incidentally. But again, just like dermoids, endometriomas do grow over time. So typically it's really just a matter of time when you would have it excised if you're trying to wait. Fun fact is that they're often called chocolate cysts because they're filled with dark, thick fluid that looks like melted chocolate. So, but yeah, the main thing to know is that endometriomas absolutely impact fertility, and also it can be a sign of advanced endometriosis. So on the ultrasound, you could see the endometrioma, but you really can't see all those other endometriotic lesions or implants elsewhere. So if this is the situation like is in this cartoon, this is stage 4 endometriosis. So really it could be a sign of, think that things are pretty bad inside, and can be an indication that surgery is necessary, even if the endometrioma is small, and there's not a lot of symptoms. Beza, should I do questions now or?
Yeah, I neglected to mention that if you have any questions, please go ahead and put them in the chat box. We usually take a pause to address any questions you might have. So if you have any, now would be your opportunity to go ahead and drop it in the chat box or in the Q&A. I'll let you know if anything pops up, Dr.
Okay, sounds good. Let's see, let me just make sure. Okay, so next one, cystadenoma, also considered a complex cyst, but these are just, again, not cancers, very benign, but can get very large. So typically these don't cause pain, and usually they present as just somebody feeling really bloated, or they feel like their belly is getting large. Maybe they feel like, oh, they've gained a few pounds, but when they get an ultrasound, there's actually a big mass there. It's typically these are filled with clear fluid, which is called serous cystadenoma, or like this gelatinous mucus, or called mucinous fluid. They require surgical excision because just they get, big over time. And this is like a little picture. I don't know this guy, but he's holding this large ovary with the cystadenoma. The thing is that you do not have to have open surgery to have these cystadenomas removed. This patient obviously had open surgery because this whole thing is completely intact. But typically we do these laparoscopically, and all of the cysts that I've mentioned so far are taken out laparoscopically. If the cyst gets to this point, if it's this large, it can be done laparoscopically, but you're probably not saving the ovary because there's no ovary left in there. It's just all now become big cysts. So that's why, again, delay in care is not always helpful. And again, so this is somebody with a very large ovarian mass, and this is same person with the mass removed, and they had laparoscopic surgery, so they did not need a big open incision to take out this mass. Fibromas also can get very large. So these are common in all ages, not cancerous, completely solid. So where cystadenomas were fluid filled, like a big bag of water, this is a completely solid tumor. They're close relative to uterine fibroids, and do require excision. And when they get to this size, there's no ovary left. TOA. So this is sort of looks like a cystic mass, but it's really an infection. So it's a collection of infected fluid that's localized to the tube and the ovary on one side. So you could have it on both sides as well. And it's caused by untreated pelvic infection. Typically, the source would be through sexual intercourse. It presents usually with pain and fever, and typically patients would come into the ER and they'll get, examination. It would show elevated white blood cell count, which indicates infection. It can absolutely lead to infertility because even after the infection is treated, the tubes are usually blocked permanently. And this condition does require IV antibiotics, possible surgery. So, for example, if you had a tubovarian abscess and it was treated with antibiotics and the infection has resolved, but there's continued pain, this may be due to scarring, maybe due to the tubes still being filled with fluid and causing pain. So once the infection is completely treated, we sometimes go in laparoscopically and take down scar tissue or take out the fallopian tubes. These fallopian tubes that stay dilated like this are never going to be functional again. Sometimes if the infection is treated, then the tubes sort of, the fluid goes away and the tubes become normal, then they could be normal in the future. But if the tubes stay the sausage looking thing, even after the treatment, then it's done. So the only way for a patient to get pregnant at that point would be to remove the tubes, and then they would do fertility treatments. All right, so treatment options for ovarian cysts, and I kind of touched on everything as I was going through each one, but just to recap. So observation suitable for small, simple or functional cysts with no symptoms, right? So if you have a functional cyst, we don't do surgery for those because they go away on their own. If it's a small, simple cyst, so let's say you have a cyst that's persistent, so you get an ultrasound and it shows a 2 or 3 centimeter cyst, and then you get another ultrasound in 3 months and it's still there and it's still the same size. I mean, you could leave it. If it's small, if it's simple, if it's not increasing in size, if it's not causing pain, that's fine, right? So you don't need to do anything. Observation is not appropriate if there's pain or if we can't really be certain that there's not a malignancy. So if it's a complex cyst, if it's not a simple cyst, there's a small possibility that there can be cancer. So we can't just say, let's just observe, right? Surgery, again, laparoscopy, right? So it involves excision of cysts. In majority of the cases, the ovary can be preserved. So even if you have a large ovarian cyst, and we're not, I mean, you know, large, I guess there's a range for large. So unless it's the size of the cyst that the guy was holding, but, you know, if it's this big, 10, 15, possibly even 15 centimeters, you could potentially preserve the ovary depending on the type of cyst and depending really how it looks during surgery. So if there's some ovarian tissue still there, we could preserve it. Is it going to be highly functional? Big question mark, right? So if you have only 10% of the ovary remaining, is it worth saving that ovary? Probably not. Open surgery is not necessary for very large cysts. There's a technique that can be used to address a very large cyst without making a big incision. If you have pain, surgery is indicated regardless of the cyst size, right? Because the cyst may be just an incidental finding and there might be something else going on, all right? And then just to review what laparoscopy is, that's just putting a thin camera through an incision at the belly button to look, and then another incision is made in the bikini line where we actually remove the cyst or take down scar tissue. So this is an outpatient surgery, and typically recovery is about 3 to 5 days.
Dr. D, can we take a pause and take a
Mm-hmm.
couple of questions?
Yep.
So you could go ahead and see them in the chat box. We can start with what size measure is considered a large cyst?
So it's all subjective. I don't think there's like classification, what is large, what is small. I think again, if it's causing pain, it's really, if you have pelvic pain and there was a cyst identified, I think the next step would be to consider laparoscopy, right? Because you're trying to investigate what's causing the pain. Maybe the cyst has nothing to do with the pain, right? And the cyst was just an incidental finding and it would resolve on its own. But if the pain is there, it may be a sign of endometriosis. If you have a dermoid, or, if let's say you pretty much know what type of cyst this is, and this is a type of cyst that would require surgery, I would say it doesn't have to be the size of a melon to indicate surgery, right? Because if it's the size of a melon, you probably, your chances of saving that ovary is pretty low. So you really want to sort of proceed sooner than later. So I think 4 to 5 centimeters is already reasonable to do it, even though overall it's not considered a large cyst. But again, if the goal is to save the ovary, then you want to do it when the cyst is still small rather than when it's 9, 10, 11 centimeters or more. Can you have continuing issues with endometriosis if you've had complete hysterectomy? So that's a slightly different topic, but yes, you can, and there's, different factors, and we definitely cover a lot of these in our endometriosis webinars. Are ovarian cysts and endometriosis hereditary? I mean, endometriosis is extremely common, so we do definitely see patients who have family members who also had endometriosis. Ovarian cysts are just common, right? So there are different types of cysts, and some of them are, not hereditary at all, but some of them are just, very common. I had surgery almost 2 years ago for fibroids and endometriosis. I'm also prone to ovarian cysts, and often starting birth control. And after starting birth control, I've had a period on and off for the last 2 months and ovary pain. How can I prevent or stop this from happening? I haven't had children yet. I would still like to. So, I mean, if you're on a birth control pill and you're having periods off and on, I mean, they could be just due to the pill, and the uterine lining is very thin, so that's not necessarily abnormal. But ovarian pain is abnormal. If you had surgery for fibroids and endometriosis, could be pain due to endometriosis that you're feeling. If the ultrasound is normal and it's not showing new fibroids or ovarian cysts, it could very well be endometriosis causing the pain, and you may require another surgery. Could adhesions occur years later after the ovary is removed, affecting small bowel, causing pain that intensifies over years? So you can have adhesions, so adhesions is scar tissue, which can form after really any surgery. But typically with laparoscopic surgery, adhesions are less common, but again, depends on sort of how extensive that surgery was. Was there endometriosis? Because that can also cause scar tissue, and scar tissue can affect your bowels, small intestines especially, because we have, right, really feet and feet of long, small intestines, and if you're standing up, you have small intestines all piled up in your pelvis. So if there had been surgery prior, that the small intestines can stick to other structures. They can stick to ovaries. They can stick to uterus if you've had a myomectomy or fibroid removal surgery. So yeah, so scar tissue can form. It doesn't form years after, it forms after you've had surgery, but it can cause problems years later. When the patient, will the patient be put to sleep during laparoscopic cyst and fibroid removal? Yes, the patient is put to sleep. All right, so we do use general anesthesia that's administered by the anesthesiologist, so you're completely asleep. And oh my good. Okay.
Yeah, we can come back to any questions.
Come back.
Yeah, so
Okay.
let's proceed just so we get through everything we have.
Okay, sounds good. All right, so I think I covered it, but let me just go over it again. So laparoscopic management, right? So indication would be persistent cysts, pain, complex cysts or mass, discharge home same day, right? So it's outpatient procedure, general anesthesia, recovery 3 to 5 days. Incision size, so you would have one incision that's 1/4 inch at the belly button, and then a second incision in the lower bikini line, about 3/4 inch. It can vary if, let's say, there's this mass or cyst is very, very large, or if there's a lot of scar tissue, sometimes we add a 3rd incision, but 90% is just the 2 incisions. Pain, mild to moderate. I mean, pain is subjective. I think some patients do better after surgery than others, but of course we prescribe pain medications. Procedure time can range between 15 minutes to about an hour. If there's a lot of scar tissue, maybe longer. So with endometriosis surgery, or if we find extensive endometriosis, can be longer. So for example, yesterday I did surgery on someone who's very young, and she presented with pelvic pain, said she's had very painful periods, and the ultrasound identified cysts on both ovaries that were thought to be endometriomas, so endometriosis cysts. She went in for surgery. So it was confirmed during surgery that she had endometriosis cysts to both ovaries, but also was found to have very extensive endometriosis in other places, including the rectum, which is the large bowel. So that surgery, the plan for the surgery to be about less than an hour, but the surgery ended up taking longer because so much more endometriosis was found and had to be removed. So conversion to open. So this is meaning that, what are my chances for having the surgery laparoscopically and then waking up with a big open incision? So that's very rare, all right? And that's going to be dependent on several factors. I would say number one is that surgeon's ability or skill to get the surgery done laparoscopically. That's why it's very important to ask the person with whom you're consulting about surgery, how many surgeries do they do per week or per month, how many laparoscopic surgeries they do, right? You don't have to specifically talk about, how many dermoids do you remove per year, but you can just in general term, right? So if they do 10, 15 laparoscopic surgeries a week, then you should feel pretty comfortable that they can take out your ovarian cyst, right? Because laparoscopic surgeries, ovarian cystectomies are not all that complex typically. So if they're doing hysterectomies or myomectomies, which is fibroid removal surgeries, then and all of these are done laparoscopically, then they should be able to handle ovarian cysts. In rare cases, if we, let's say, go in thinking this is benign and this is cancer that's spread everywhere, may require a larger incision. Again, majority of the time, these are completely benign and can be handled laparoscopically. All right. The CIGC difference. So, our conversion to open rate is extremely low. Also, ovarian preservation. So I would say that's probably number one cause why patients come to us kind of for a second opinion, because most of these cysts occur in young women, right, who are trying to preserve fertility. And even if you don't desire fertility, ovaries are not just for eggs, right? Because ovaries make hormones. And you need those hormones in premenopausal age. So it's not always just about fertility. But typically we see, so patients like coming in with 8, 9, 10 centimeter cysts or larger saying, okay, I was told that I will most likely need to have my ovary removed. And I can tell you that, those measurements, you really don't need to. When you start getting into like 15 and above, yeah, there's probably nothing to save. It's not that we can't save the ovary, it's just that there's no ovarian tissue left. But typically at 10 centimeters, there's still something there. Is it going to be a 100% functional ovary? No. But you can definitely preserve the ovary, especially with dermoids. Those, even though get large, there's still good ovarian tissue remaining. The complications, right? So what are some potential complications of surgery? So infection, bleeding, pain, injury to bowel, bladder, so injuries to surrounding structures. So we deal a lot with endometriosis, so our complication rates are going to be lower because endometriosis makes these cysts stick to structures. So where dermoids, they're just, and that's why they can twist. Dermoids, an ovary with a dermoid typically is not stuck to anything. It's just completely mobile, and that's why torsion is more likely. And endometrioma is stuck in place. It's like somebody poured super glue on top of the ovary, and it just sticks to bowel, it sticks to the uterus, all the surrounding structures. So it does require special training to be able to take care of it without, causing complications. And volume, as I mentioned, right? So you want to ask your surgeon, how many laparoscopic cases do you do? And, I wouldn't even say a year because it's like, so it's like if somebody asks you, how many times do you drive a car per year? You would be like, oh my God, I don't even know. Like, it's just so many, right? So you typically for something, you want to think of it as something that they do commonly, almost on a daily basis. So, right. So you would ask per week. If you want, you can ask per month, but that will give you a better idea. So typically, I would say at the very least, you should be doing 5 surgeries, laparoscopic surgeries per week. I would say the very minimum. So that would be, good amount of volume. But most high volume surgeons, somebody who specialize only in laparoscopic surgery, so they're not doing other things, right? They're not delivering babies, they're not doing, pap smears or well woman exams. So somebody who's solely specializing in surgery, in laparoscopic surgery, that's going to be majority of their practice, right? What else do they have to do? I mean, if they're working full time, they're going to be doing surgery, and then they're going to be seeing patients in the office after their surgery, or patient consultations to talk about having surgery, right? So there's not, the scope of the practice should be really surgery. That's it. So conclusion, I think I feel like I've said the same thing multiple times, but conclusion, ovarian cysts and pelvic masses are very common, and most are not cancerous. So if you have, especially in the premenopausal age, if you've been diagnosed with an ovarian cyst, ovarian mass, first of all, just take a deep breath. Most of these are not cancerous, but don't think that it's nothing, right? So it still needs to be investigated. Because these can cause infertility, pain, and they can get very large, right? So you want to take care of that. But even if they're asymptomatic, if there's no symptoms at all, and this is a growing mass, you still need to think about getting it removed. Diagnosis typically made through pelvic ultrasound, and again, surgical removal to preserve the ovary, to decrease the risk of pain, or really to make the surgery as least complicated as possible, is important. And so delaying care typically, is not recommended. All right.
Thank you so much, Dr. D. We'll take questions in the we have one in the chat box right now, but now we have plenty of time. So if you have any questions, please go ahead and
yeah. So all right, so this is from Florence. I'm having heavy bleeding, and I have had a laparoscopic, I'm going to say something that was done laparoscopically. What can slow down the bleeding? I think it depends on what the bleeding is, due to, right? So if the fibroids are causing the bleeding, you have to address the fibroids. If it's overgrowth of the uterine lining, that has to be addressed. So it really, you just have to go to the root cause. Thank you, Christina. I'm glad you enjoyed the presentation. Yes, Beza will be sharing, right, the presentation after. So after the 3 to 5 day recovery, can the patient drive, resume normal activities, board a plane, etc.? Yes, so definitely board a plane, right? Because a lot of times we see patients, they're actually traveling from a different location to have their cysts removed. So you can travel typically within 2 to 3 days, just kind of depends on your schedule. Can the patient drive? Depending on if you're not having any pain anymore. So after a few days, if you're feeling well and you're not having any significant pain, you can drive. Same thing with normal activities. So typically your restrictions are going to depend on how you feel. If you're still, very sore, and especially if you're still taking pain medications, so narcotic pain medications, that would be your sign that you shouldn't be driving. All right. Yeah, and I think with Florence, yeah. So if you think it's fibroids, I think you just definitely have to get the fibroids addressed.
All right, this has been great. Go ahead and please, I just shared a link. So if you're still with us, it's an evaluation, a link to an evaluation form. So take a moment to complete that. It really is going to help us improve our future webinars. Just an FYI, we do these presentations almost every month. And again, the goal is to be able to empower you all with information you need to make informed decisions. So for example, if you're interested in fibroids, we have a webinar coming up in February and also in April where our one of our PAs is going to be discussing their relationship to vitamin D. So if you are interested in just kind of following us in terms of these webinars also, go ahead and subscribe to our mail mailing list so that you can get these notifications every month. Recording would be shared, like Dr. Danilyants mentioned earlier. We would share them both on our YouTube channels, and also if you have registered for the webinar, I'll share it in an email. And one thing that I'm just going to go ahead and emphasize, Dr. D has said it throughout the webinar, is do not delay care. As the public relation manager here, I always talk to our patients post-surgery, and something that comes up quite often is that because our patients go from a specialist to specialists that are not necessarily specialists, by the time they come to us, they have suffered for years. So, and one thing that they often say 99% of the time is, I wish I did not wait until to get a consultation. So if you're interested in getting even a consult, go ahead and go. I will share a link. You can go ahead and schedule it with us. We're very prompt, so we'll be able to, one of our PCPs is going to be able to reach out to you. And so I'll go ahead and share that link both in the chat box as well as in my email. So thank you all so much. If I miss any, we have one more question.
I think we have a couple more questions here. Yeah.
So we'll go ahead and address these questions. So stay with us. We have until the end of, well, until 1 p.m. So go ahead, Dr. D.
Yeah. Yeah. So Shalisa is asking, she has an appointment on Thursday to talk about bleeding. Would ask the doctor, I mean, I'm assuming your doctor would get a pelvic ultrasound. If they don't, then ask for one, because so pelvic ultrasound, right, is a really easy test to identify most of these GYN conditions. So fibroids. So if we're talking about abnormal bleeding, definitely an ultrasound would be the first step. Can you still develop cysts and fibroids after complete hysterectomy? So it depends on what you mean by hysterectomy, all right? So hysterectomy technically just means removing the uterus. So because ovarian cysts come from ovaries, if your ovaries are still there, then you can develop cysts. Fibroids, if we're talking about uterine fibroids and you had the uterus removed, then no. But if it's a fibroma, which is a fibroid-like mass of the ovary, then the answer is yes. So if you still have your ovaries, then you can develop cysts. If the ovaries had been removed at the time of the hysterectomy, then you should not have any cysts. There have been times where I've done surgery on a patient who've had a hysterectomy previously with the ovaries removed, but there was a small remnant, ovarian remnant, so a piece of the ovary was still in place. And that can happen if there's a lot of scarring at the time of the surgery. And the ovaries are, stuck, let's say, and the surgeon goes to remove the ovaries and the piece of the ovary still remains there. Technically, that small little remnant can develop a cyst. So anytime you have a pelvic mass or a cyst that's found on imaging, and let's say you say, well, how can it be? I already had my ovaries removed and uterus removed. You still need a laparoscopy to figure out what this mass, where this mass is coming from, and still have to have it removed. So what else? Let's see. What would you do an ultrasound at the office during a consultation if only CT and MRI were done before? Well, yeah, if you've had a pelvic MRI, you don't need to do an ultrasound because that's sort of a step down. Think of it, the ultrasound is just like the very basic test. MRI is, a little bit more extra. So like a fancy restaurant versus just the one that you go on any weekend. So if you already had an MRI, you don't need to do an ultrasound typically. So the MRI should be fine. And you're very welcome.
All right. I think we have gone through all the questions. If once we end this webinar and you happen to have a question and you want to just shoot me an email, you could also do that, and I'll make sure that Dr. Danilyants get them and address them. So we're going to end a little early today. So thank you so much, everyone, for joining us and being on the lookout for an email from me. Thank you, Dr. Danilyants, as always. This was amazing.
Yeah, I'm glad
So
everyone enjoyed it. Yeah.
I'll go ahead and stay on for about a minute or so. So I'll give you an opportunity to go ahead and complete that evaluation. And Dr. D, I'll see you on the other end.
Okay.
Bye.
Oh, wait, I think there's one more question here.
I think
It
people
just
are just
popped up.
saying thank you.
Okay.
Just
Thank you. Okay.
yeah.
You're welcome. Thank you. All right. Take care.
All right.
Bye.
Take care. Bye.